So without further ado, I'd like to introduce our first speaker, who is Adi Cooper, OBE, who's the Local Government Association Care and Health Improvement Lead. And she's going to be talking, the first speaker, about the role of safeguarding adults and women's mental health. Over to you, Adi.
Thanks, Liz. So I'm going to set a bit of context using the work that we've done through the COVID Adult Safeguarding Insight project. Thanks. If you could do the slides, that'd be brilliant. So this report that I'm talking to has been produced by myself, Anusri Biswas and James Harmon at the CHIP program, the Care and Health Improvement Program, which is where I lead on safeguarding adults. So if we move on to the next slide, just to say that, where did this work came from? It came from the need to understand what was going on with safeguarding activity during the COVID pandemic. And what we needed was some idea of local insight on a monthly basis on what activity was happening, because we didn't know. There were a huge level of concern around the impact of COVID on adult safeguarding, and we wanted to understand what was going on in order to learn lessons as we moved through the pandemic. The Safeguarding Adults boards were really key, and sector colleagues, in asking for this sort of information to be collected, because there was no other database. The normal data collection on safeguarding activity comes through NHS Digital, and it's usually an annual return that tells you about what's going on through the whole year, rather than what's been happening during the year. So moving on to what we've done, and we continue to do, is we ask people, if you could move on to the next slide, we ask people to give us their information on a monthly basis on what's happening. And we ask them to go back to the previous year, so right back to January 2019. So we could look at what was happening differently between 2019 and 2020. And we used questions that are collected where the data is collected normally, so information that people were used to providing. And that information was collected. And we also asked for people to tell us what they were seeing, not just the data, but comments on what they were seeing happening in terms of safeguarding activity during the pandemic from last March. Obviously, there were a lot of local variations in terms of how COVID impacted in England. There were different circumstances, and there were changes in safeguarding practice. And I would put in a caveat that also we didn't ask specifically about mental health and gender and women, but you'll see from hopefully this presentation that we have got some insight that's relevant to today's webinar. So if we move on to the next page, you'll see how we were successful in getting a really positive response from councils. So over 67% of councils participated, and half of those, or a third of those, provided us lots of information about what they'd seen. If we move on to the next slide, I'll tell you what we've been finding out. And this information that I'm sharing with you today covers information up till December last year. So it's during the pandemic period from March to December last year. So the first area is the concerns that were raised through adult safeguarding routes. And what we saw at the beginning of the lockdowns is a really sharp decrease in the amount and level of concerns that were being reported. But then as the lockdown lockdown eased, a very steady increase during the summer last year. And underlying this, an increase in the rates of safeguarding returns that were higher than the previous year. And that's really important because it evidences what people were experiencing in terms of the fluctuations in people raising their concerns and contacting the local authorities about safeguarding. If you move to the next slide, you'll see that presented in a graph, and hopefully you will see very clearly the dip in March and April last year. I mean, it does fluctuate from month to month, but there is a pattern of a dip and then a rise. And then as the lockdown came into force in November last year, you can see it starting to go down again. So the data shows us what we were often experiencing locally, that people during the lockdowns weren't able to, for whatever reason, report concerns, but then as the lockdowns were easing off, the concerns about safeguarding risks to people were being reported at a higher rate. If you move on to the next slide, some of the insight that people gave us was that there were increased numbers of concerns being raised by the emergency services. And if we remember back to what was happening last year, that makes a lot of sense. Friends, neighbours, volunteers were reporting concerns. Again, think about what was happening this time last year, or in March and April last year, and the level of community response to the COVID pandemic as it started. There were also a high level of concerns about people who didn't have care and support needs as defined by the guidance, but were at risk of different types of abuse and neglect. And those people were supported without going down the sort of safeguarding Section 42 inquiry pathway. And a lot of councils reported those increases and changes in the nature of the concerns that they were seeing around safeguarding activity. If you move on to the next page and next slide, on the inquiries, so these are when the people have are experiencing or at risk of abuse and have care and support needs. The Section 42 inquiries undertaken, so those safeguarding inquiries, show a very similar pattern of a decrease in the beginning of last year before increasing back to the pandemic level, and then falling down again during December as the second lockdown started. So you get a kind of V shape. If you look at the next slide, hopefully you'll see how that looks in the pattern. You get this V shaped also in the inquiries that were undertaken in terms of vulnerable people subject to safeguarding Section 42 inquiries. Moving on to the next slide. We also asked in the Insight report, we asked people to tell us what types of abuse were being reported. And we do see significantly increases in domestic abuse, self-neglect and psychological abuse when we compare the information from 2020 with 2019. And if we look particularly at where abuse happens, so the location of risk, the same three categories appear when we look at risks in people's own homes. So the next two slides might be a bit tricky to read because they're quite detailed, but you see that in the data which are represented both in this bar chart and in the next slide, which looks at it in a slightly different way in terms of people's own homes being the blue bars at the top. You see they're getting bigger and bigger. And interestingly, in the context of care homes and safeguarding in care homes, there's significant decreases in the rates of safeguarding inquiries, which the detail of this bar chart, if you can see, shows to some extent. So moving on to the next slide. What did councils tell us? They said there was an increase in complexity. So what the numbers don't tell you is what the detail of inquiries, that there was impact of the pandemic and lockdowns on domestic abuse, that more people were being identified as self-neglecting through outreach to clinically vulnerable residents. So there were whole groups of populations, of local populations that councils reached out to during the pandemic that maybe previously weren't known to adult social services. And what's really important for today's event is that there is evidence that was reported through this project of increased mental health needs, particularly related to self-neglect, which is a category for safeguarding, as people will be aware. So we do have evidence in the Insight report of councils telling us of these patterns of change in terms of the nature of safeguarding activity. Moving on to the next slide. We also wanted to point out that safeguarding activity data is only part of the picture, and that it doesn't tell you the sort of nuances of experience that people had through the pandemic and lockdowns. It does clearly point to the impact that the pandemic had in terms of mental health, in terms of domestic abuse, psychological abuse and self-neglect. And other information which I'm expecting will be shared this afternoon will show how those impacted differentially on women, particularly, for example, the impact on women as carers. So just in terms of the data that we already have from other sources, we know that more women than men have caring activities, and that the lockdown and the pandemic had a disproportionate effect on carers. Huge numbers of people became carers during the pandemic that weren't carers previously. So moving on to the next slide, which pulls out some of these points, there is evidence of the learning that happened, that fluctuations in safeguarding activity through subsequent lockdowns were less pronounced, i.e. people learned from the first lockdown how to prepare and anticipate the impacts of lockdowns that were being introduced in terms of COVID. And the Insight report, which is due to be published very soon and is about to be circulated, the second report, provides really useful case studies of how people have responded to the challenges that the pandemic has presented to us. So hopefully, Liz, that will help provide some context to the speakers later on in the session about what we know about safeguarding activity during COVID and the lockdowns to date, or to the end of last year, and how some of those issues particularly impacted on women and mental health. So thank you for inviting me to speak today, and hopefully that provides a useful context for the webinar this afternoon.
Thank you, AD. That was excellent. And I do appreciate we could talk for a lot longer on that topic, but it does provide some really helpful context. Just to remind everyone that the slides will be shared and that the recording of the webinar will also be made available to delegates for any slides that weren't easy to see during AD's presentation. So thank you, AD. Our next presenter is Lucy Hadley, who's the Head of Policy and Campaigns, Women's Aid Federation England. And Lucy's going to speak to us about the national picture in terms of women's mental health. So over to you, Lucy. Thank you.
Thank you. Good afternoon, everyone. It's good to be here today. Hopefully you can see my slides. I'm going to be talking, as I said, about the impact of COVID-19 on survivors of domestic abuse and their mental health. I'm going to talk a bit about Women's Aid and our the work of our Federation of Member Services delivering support to survivors and their children, what we know about the barriers women face to accessing support and their mental health support needs, and the impact of COVID-19. And finally, I'm going to talk about some of the work we've been doing with adult social care to try and address some of those barriers and meet those needs. So a bit about Women's Aid for those who don't know who we are. We're the national charity working to end domestic abuse against women and children. So we provide some direct services nationally, including a live chat helpline and specialist support for women facing barriers accessing a refuge space. But we also use national data sets and research to campaign for change in policy and law, and we hold the largest national data set on domestic abuse in England. We do a lot of work with training professionals, including adult social care, children's social care, health professionals, police officers and many others, to improve responses to domestic abuse. And I'm going to be talking a bit about the approach that we've developed over the past 5 years to really try to ensure that all survivors get the right response to domestic abuse first time, and that's called our Change That Lasts programme. really importantly, we're not just a national organisation, we're a federation of 170 life-saving services across England who deliver a range of expert support to survivors and their children, and developed from the 1970s into what's now a national network. We also have sister federations in Scotland, Wales and Northern Ireland who do very similar work to Women's Aid in England, but we operate separately. So thinking about who is supported by those local services, we know that the domestic abuse services provide a wide range of support, both in refuge services, but also in the community. And that can be through helplines, support groups, outreach, peer support, advocacy, specialist support for children and young people, and many more. And Women's Aid nationally collects data from those services, both inside our membership and beyond, to build a robust picture of service provision for victims of domestic abuse across the country. So from the basis of the data, we know that in 2019 to 2020, just over 11,000 women and over 13,000 children were supported in refuge services in that year, and over 156,000 women and nearly 190,000 children supported in community-based services. But as I'm sure you won't be surprised to hear, demand for that support remains really high, and the sector is unable to meet the demand of survivors who need our help. So over half, 57% of referrals to refuges in that same year, 2019 to 2020, were declined. The main reason for that was due to lack of space or capacity to support the survivor. And there's still a 30% shortfall in the number of refuge spaces that England is required to have. And that means that daily women and children are being turned away from the life-saving support they need. We also know around a third of referrals in that same year to community-based services will decline. So there's a huge level of an unmet need in the specialist domestic abuse sector. I also want to recognise that those numbers and those that data on referrals and the numbers of spaces actually masks real inequalities about the barriers that different groups of women face to accessing that support. So just 4% of refuge spaces in that year could accept a woman with no recourse to public funds due to her immigration status. Of all refuge vacancies, just under 1% had full wheelchair access. And importantly for our discussion today, only 15% of refuge services had specialist mental health workers and 10% had specialist drug and alcohol workers. And those proportions have been falling over the past, kind of year on year over the past decade, really reflecting the impacts of cuts and austerity. So we know that for many services, that just means they are unable to safely accept a referral from a woman with significant mental health or substance misuse needs, because they have to be able to support her safely alongside the other women and children in the refuge. So as I mentioned, we also have a specific project that looks at the barriers that women face to accessing a refuge space and provides them with dedicated support if they're struggling to access one. We see a very significant proportion of Black and minoritized women every year that are referred to that project because they're facing barriers to accessing refuge. That was 43% in 2019 to 2020. Nearly 30% had one or more disability, and a quarter had no recourse to public funds. So we know that the spaces that there are in refuge across the country are not enough, but we also know that women facing additional forms of inequality and discrimination face the greatest barriers to accessing the help they need. And I'm sure Janae will be talking a bit about more about the specific barriers that Black and minoritized women and women with insecure immigration status face in accessing help and support. And I think these gaps in provision support are really so much more concerning when we actually think about the level of support needs that women using domestic abuse services have. So around over a third, 36% of women using domestic abuse services in 2019 to 2020 had mental health support needs. And that figure was really high, over 48% in refuge. And similar proportions reported feeling depressed or having suicidal thoughts as a result of the abuse. And again, that proportion was very, very high in refuge. I'm sure, as we're going to talk about today, domestic abuse has a huge impact on women's mental health. Survivors of domestic abuse are survivors of traumatic experiences as a result of the oppressive and the coercive and controlling behaviour that they faced by perpetrators. And these tactics are likely to increase in frequency and severity over time. And that means a repeated exposure to abuse and trauma is likely to have very serious consequences on the survivor's thoughts, on her feelings and her behaviour. I think it's really important to say that the relationship between mental health and domestic abuse isn't a linear one. We know that perpetrators specifically manipulate survivors that may have mental health problems as part of their abuse. And we also know that abuse can exacerbate pre-existing mental health conditions and, of course, lead to the development of new mental health illness, including PTSD, severe anxiety, depression, eating disorders, self-harm, and suicidal thoughts and actions too. And I think, these statistics show really starkly the severity of domestic abuse on women's mental health. And remember that these are figures from women using domestic abuse services, not those who are unable to access support at all. So you can imagine it would be even greater. And I think this co-occurrence really shows why we need adult social care services to be routinely investigating experiences of domestic abuse for any woman with mental health support needs. Thinking about the impact of COVID, we obviously know that the pandemic has had a really severe impact on women and children experiencing domestic abuse over the past year. We know that abusers have used COVID as a tool for coercive control, and also that the lockdown context really limited routes to support and safety. So as the previous speaker was talking about, we might not have seen, we might not have seen the full impacts of the harm that was being experienced until lockdown measures lifted, because it was so difficult to report and so difficult to access help. We published a report in August of last year called A Perfect Storm, which is on our website, which details this in full. But today I'm just going to focus on the mental health impact specifically. So we know for women living with their abuser during lockdown, they were trapped. And it was clear from many of the experiences that we recorded that women were experiencing increased fear and anxiety as a result of those circumstances. Several women told us that they were suicidal due to the situation. One survivor said lockdown has made it harder to have hope for the future and get support. We also know that for those who'd experienced abuse in the past, lockdown was re-traumatizing. So 53% said it had triggered memories of abuse and affected their mental health, and 23% had said it made them feel more afraid. One woman told us, living with my ex felt like being imprisoned in my home. This lockdown has brought back feelings of fear, loneliness, and isolation. We also know there were really additional barriers to accessing mental health support during COVID-19. So 2/3 of survivors currently experiencing abuse who needed mental health support were unable to access it during lockdown. Women told us about counselling services and groups being stopped, trying to access them online, but being unable to because the perpetrator was in the house. And that was also a common experience for those who'd experienced abuse in the past and were trying to access mental health support as part of their ongoing recovery and journey. And finally, really important to say that it had very significant impacts on the mental health of frontline staff in specialist domestic abuse organisations, and I'm sure in many adult social care teams too, supporting survivors experiencing horrific levels of trauma from your bedroom with your children around. Trying to homeschool was a huge burden and has had a real impact on our sector over the past year. The levels of burnout and stress that have been experienced are really very high. So that is a very bleak picture, and we're all here today because we want to do something about it. So I want to end on a more positive note about the important role that adult social care staff can play in recognising survivors and enabling them to access specialist support. I know that ADASS and the LGA found in 2015 that despite the very clear overlap between the needs of people experiencing domestic abuse and safeguarding adults work, the two have developed as very separate professional fields. And there's a lot of work going on to try and address that gap. I just want to talk about some of the work we've done at Women's Aid to do so. So as I mentioned, our Change at Last approach, which was developed in partnership with Welsh Women's Aid and with survivors, is really aims to place the survivor at the heart of the response and ensure that whoever she comes into contact with, she gets a strengths-based, a needs-led and a trauma-informed response. I know that sounds very jargony, but it's really ensuring that her needs are met, that she's met with the kind of supportive response, the links and referral to specialist women's services that she needs. And it's made up of 3 strands across the community that aim to make that happen. So Ask Me is in the community. I'm not going to talk about that in detail. I want to talk about the trusted professional response, which is really relevant to what we're talking about today. So it focuses on professionals in services who are already in contact with and trusted by survivors. And it's a 360-degree intervention in services, so it encourages systems change within an organisation. It consists of a review into an organisation's practice, a review of your data and policy, focus groups with survivors that have already worked with your service and have come into contact with your professionals, and that informs training for professionals and staff with ongoing learning and development to ensure that services are really challenging perpetrators, improving responses to survivors, and that professionals have the skills and understanding to support women appropriately. I'm not going to go into too much detail about it because I don't have time today, but here are some things that really make up the heart of the Change at Last response. So what survivors really need, what they tell us they need from professionals to be respected, updated, believed, heard, protected, empowered and supported. And it's really about breaking down the barriers to disclosure from women by equipping professionals with the skills and knowledge to identify coercive control effectively, to understand the trauma caused by domestic abuse and respond in a trauma-informed way. It's not about adding to existing workloads or distracting from your responsibilities. It's about building those skills and that understanding. It's also really not about a trauma-informed approach is not about treating the trauma symptoms that a service user might present with. It's about ensuring that you cause no further harm to the survivor. And that involves establishing her physical and emotional safety, trustworthiness, maximising her choice and control, which has been stripped away by the perpetrator, and prioritising empowerment as well. And it's been part in a number of areas, but specifically with adult social care in Surrey, who had identified very significant underreporting of domestic abuse within their caseload and issues with identifying coercive control amongst survivors. The training that we provided had really positive results in terms of improving the confidence of professionals to respond effectively to disclosure of domestic abuse, improving professionals' confidence to understand the needs of survivors, and to support survivors with their role. And the full evaluation of this programme is out soon, and we can ensure that that's circulated within ADASS. And I hope it will be helpful for improving your practice and responses to domestic abuse. Thank you.
Okay, thank you, Lucy. Again, a topic that we could spend a lot more time on, so thank you for being so concise. Just to let delegates know that the link to the second Insight report is available in the chat and will also be made available after the webinar. So I'd now like to introduce our third speaker, who is going to talk to us about her lived experience. It's Alexis Quinn, and she's going to speak to us about what local authorities should know and what they should be doing. So welcome to Alexis.
Hi, thanks for introducing me. I'm just going to share my screen. Everyone see that? So great.
Yes, thank you.
All right, so I'll just tell you a little bit about myself, just to kind of just to set the scene. So, I mean, basically, I was a successful student and GB athlete as a child, and as an adult, I worked as a teacher. And crucially, the environment which I grew up in and remained in as an adult was really routined. It played to my strengths, and most importantly, my sensory needs were met. Like most autistic people, I managed well until I didn't manage at all. For us, it really is a sink or swim scenario. And if you start sinking in the community, I suppose the help you get offered is pretty sketchy. So 2 things happened to trigger my crisis. My brother died, and I also had a baby. And, pretty normal stuff, social issues really to start with, not medical ones. But pretty much all the rules that I used to govern my life didn't apply anymore. And my environment, which was, really organized, was now like super chaotic. And I couldn't manage. My sensory world was on fire. I needed help. And, I asked for help like you're told to. I went to the GP. And I didn't get any. I didn't get an OT assessment, some help with sensory and day planning, speech and language therapy to help me communicate my needs, or a psychologist or whatever to help with my bereavement reaction. Instead, I was advised to go into hospital for 72 hours to have a rest. And as soon as those doors shut, my environment was just totally intolerable. Everything about the hospital, in a psychiatric hospital, was pretty much, the antithesis of what autistic people need. Yeah, it's chaotic, it's noisy. There's different care workers, disturbed patients, a lack of routine, away from anything familiar. Just a real disconnection, from the secure attachments that I had at home. And I knew that I'd made a mistake as soon as those doors closed. But it was too late. All of these labels that you saw on this slide here, they didn't matter anymore. Yeah, I was there to be treated, for mental illness, which of course autism isn't. And this is how it felt. Yeah, this is how it felt. My eyes felt like they were burning, and my ears were felt like they were being drilled. My skin was on fire. My clothes were uncomfortable. I wanted to take my clothes off. And this is a typical autistic reaction, right, when there's a lot of stress, and it's called sensory overload or an overload. And I started to exhibit more troubling features as a direct response to the environment. And I spent a total of 3.5 years in inpatient units, because what would happen is I would get overloaded because of the environment. I'd have a meltdown. That would be met with a restraint where 6 to 10 people would pin me to the floor and inject me. Then I'd be secluded, and then I would have an overload again, and I went round and round and round in this circle. And over the years, I had more than 97 restraints, 17 seclusions, and I was long-term segregated, which is where you're locked in a room for, it can be days or weeks or years. And I eventually escaped the system, fleeing to Africa whilst I was on a section. And now I work as the manager of the Restraint Reduction Network. So, why is this important? Why am I sort of talking to you about this today? Well, it's really important to think about why this very common story happens and what the impact of the pandemic is on people like me. And in part, it was enabled to happen because of how we conceive of autism in women and girls. Yeah, there's a diagnostic gender bias. As we know, waiting times, which were already too long, are now even longer. And this can have a real devastating impact if you've got to wait years to understand why you're reacting in that way that I just described. So at the moment, 1 female to every 4 to 5 males are diagnosed autistic. Girls fly under the radar. And this is due to insufficient knowledge. And this is important, this bit, our autistic gendered characteristics. Now, the pandemic has meant that girls who are excellent at masking, right, who display subtler, stereotypical, behavior presentation than boys, are struggling to get diagnosed via Zoom assessments, where they're being made available. For example, I know a young girl who was spending 5 hours straight drawing Disney characters and discussed this in the Zoom consultation. And the mother couldn't get her to stop, nothing unusual, said the psychologist. But her differences couldn't easily be detected on the call, you see. But if a boy did that with trains or aeroplanes and threw an aggressive temper tantrum, if we interrupted, probably that same psychologist might have been a bit more perky to an autism diagnosis. Because girls show greater interest, yes, social interests, right? We have heightened emotional and affective empathy. We've got increased imagination and better masking of social difficulties and more socially acceptable content for our narrow interests. Think back to my first slide, mine was swimming. Now, women experience more internalized challenges like anxiety, like depression. And the recent social isolation and that disconnectedness that we get has exacerbated this. You know, men are more likely to have external difficulties such as hyperactivity and behavior problems, you know, which can be more easily managed with exercise and outdoor outlets, you know, which obviously were permitted. And remember, of course, that the extra effort women put in to socially imitate neurotypicals means we are often misdiagnosed with other mental health conditions, such as personality disorders or eating disorders, you know, anxiety and depression, which I've already talked about. And that can lead you on a super wrong path. So, you know, what happens, you know, well, we struggle through life, we're cast as weird, we're labelled with other disorders. You can see on here, these are all the other disorders which I was labelled with before, you know, they kind of got to the point, the autism point. And we can't relate until, you know, that, like, for me, those social and professional demands, they just got too much. And so we crack. And even then, we might not get diagnosed as autistic. It took 2 years for that to happen for me. And the cycle of misunderstanding continues to the detriment of our mental health. Now, at this time, we must make sure that we're taking in the person's full picture. Okay, that picture that I showed you on that front slide, and understand the social context, And I think the impact of those external stressors, you know, what's happening for the person in their life? Are they getting, have they experienced, you know, greater disconnection because of the pandemic? You know, what impact has that had? For autistic mothers like myself, you know, I had additional executive functioning challenges, you know, lone parenting with no backup. You know, and that can often lead to decreased ability to tread water. Remember, I was saying it's a sink or swim thing. So look, you know, let's just make sure that we don't forget the impact of the pandemic on women and how these pressures can cause other coexisting symptomology to surface and you know, appear more sort of readily observable than autism. It's much easier, isn't it, to see if somebody's perhaps depressed or anxious, but where's that coming from? Because what it does is if we get it wrong, it leads, like I did, to the wrong treatment, and it made my condition worse, and it led to a huge amount of restrictive practice. Now, there was a high-profile case of Colette McCulloch, I don't know if you guys have seen it, who died whilst in an ATU. The same ATU, you know, that I was in, that's another case in point, you know. She was misdiagnosed until she was 30 years old, and she struggled with anorexia, OCD, and personality disorder. And like me and many other misdiagnosed autistics, her treatment made her worse. And Colette suffered the ultimate price. If anyone's interested, her parents have written a book. It's well worth the read. It's called Why Can't You Hear Me? So, you know, like me, you know, like Colette, many women are blending in, yeah, to a neurotypical centered society. It's difficult, yeah, we mask. And this is where masking is where we artificially perform social behavior, right, that's deemed, you know, acceptable by neurotypical standards. We might hide behavior that people don't think is acceptable. For example, doing like sensory modulation stuff like stimming, you know, for example, like flapping or something like that. And it's a kind of a repetitive movement. But, you know, a lot of us decide that we'd prefer to be uncomfortable and put up with the sensory strain, you know, rather than be bullied or seen as weird, you know. So we kind of stop doing those more obvious stims. You know, contrary to popular belief, you know, a lot of autistic people, not just women, you know, do want to have friends. We do want to be successful at work. We do want to have relationships. So we are working hard to act neurotypical, and really that's suppressing our true selves. And we're doing that to please you, you know, and we rehearse answers to questions or conversations, and we mimic people. But when you think of it, the pandemic's actually helped with that in a way, because we've stayed at home and we haven't had to do that. So that element hasn't been as exhausting. But now the things, you know, we're opening back up a bit, we need professionals to question, you know, that consequence of masking. You know, is the person feeling exhausted all over again? Is it having negative mental health effects? Yeah, and what's the impact been on the person's sense of self? Because as the pandemic lifts, you know, I've experienced, you know, an increased stress response. If I'm not careful, you know, that can lead to a resurgence in meltdowns due to social overload, anxiety and depression. And I mean, I remember, you know, when I was in hospital, I felt, you know, as though I'd kind of lost myself. You know, my identity was crushed and my world had crumbled and I couldn't keep it up. And people around me, you know, they didn't like the new me, the real me. And that's kind of hard to bear, and that can happen again for women, you know, as the rules lift from the pandemic. So, you know, women that come to the attention of the system, you know, might feel like they need to mask, as I say, around professionals. You know, they might have a distrust of services. I mean, I've certainly had my fair share of negative experience, you know, with social workers in the past, and many will have sort of criticised, alienated and ostracised, you know, like the previous lady was saying. You know, what we really need is to feel heard and be listened to. And I think it's because, you know, when you think about the you know, little micro traumas, you know, there's little jolts of trauma which happen, you know, over our lifetimes, they build up, don't they? And it can result in families being reluctant to engage. You know, when we experience help, it can sometimes be re-traumatizing. You know, and as more autistic people become parents, more of us, you know, will come into contact with you. And I'll just give you a very quick example. You know, I had my son a year ago during the lockdown, and I was referred to social services 3 times in the first 4 weeks of his life. The first was by a GP because I wasn't making eye contact. The second was by a nurse who was doing his injection because I wasn't making conversation with her and answering her questions quickly enough. And the last time was for wearing my ear defenders, and a well-meaning professional thought that I couldn't attend to my son if he cried. So the social workers, you know, questioned my parenting, you know, asked me how I'd manage my behaviour. You know, that was a real trigger for me. How are you going to manage your behaviour? And I felt under this great pressure to mask and to show her, you know, my best. And of course, as I said, that adds a huge amount of stress, you know, at a time when all I wanted to do, you know, was just to enjoy my baby, you know, like any other normal parent. And of course, you know, when the social worker got to know me, you know, she left as quickly as she came, but the damage was done. You know, it is re-traumatizing. So I think, you know, to take away from today, you know, just know that autism's hereditary. And if you're helping a neurodiverse child, there's a 68% chance that the parent's going to be autistic, you know, one or both of them. And they might not know that they're autistic, and they may be worried, you know, that you're involved, and they need you to, you know, what I needed was for the social worker to be, you know, open-minded and reassuring, and I think to advocate for me to those other services. Yeah, we can be excellent parents, but it's best for our well-being and that of our children that we're helped to be excellent parents autistically, and that we shouldn't have to kind of mask ourselves to make other people feel comfortable. Thanks for listening.
So our next speaker is Shirley McNicholas, who is the Women's Lead for Camden and Islington NHS Foundation Trust and the manager of Drayton Park Women's Crisis House. So over to you, Shirley.
Thank you very much, and humbled by the previous presentations, really, and lots of kind of food for thought for the work that I do already. Somebody was going to share the slides for me, so I hope they're there. As with all of you, really, we're doing a whistle-stop tour through some of the work, but I just wanted to put kind of in context, really. I'll speak a little bit about what I understand as a trauma-informed approach for mental health services, particularly. thinking about supporting women and the challenges really during the pandemic. And in some ways, not just the challenges, but actually, I think it has opened a window. It's like, you know, I work in crisis work all the time, and this crisis of the pandemic gives an opportunity for change. And I'm kind of hearing conversations and a willingness to be open to change that I haven't heard for a long time. I have worked in mental health for kind of all my adult life, and I kind of feel this is an opportunity for quite a seismic shift in the way that we kind of organise ourselves. If we could just have the first slide, please, or the next slide. So I'm sure all of you know, but just to kind of make that connection really, that certainly from my work and increasingly other mental health professionals and lots of psychiatrists are absolutely acknowledging the link between childhood trauma, adult trauma, and the development of what we call a mental health problem. It's the significantly increased risk of mental health problems in those who've experienced trauma. As people have said before, the kind of highest risk for re-victimization are those who already have a problem. And Hind Khalife, who is a psychiatrist in our trust in 2015, did a really important kind of study looking at people who were using mental health services, and she used the British Crime Survey to kind of match the experience of domestic and sexual violence in the last year and over a lifetime, and having a mental health problem or using mental health services. And it was just, the correlation was incredible, and it's a very useful piece of research really for anyone who doesn't believe the absolute correlation between developing a mental health problem because of trauma of domestic and sexual abuse as a child or as an adult, or the re-victimization of people who are vulnerable due to their kind of mental health. Maybe low self-esteem, isolation are kind of perfect partners for perpetrators. So in that particular study saw the risk of the relationship between childhood sexual abuse and most mental health problems. And I think other speakers have talked about the strong correlation between depression, anxiety, developing eating disorders, but really we're finding more and more evidence to absolutely say that the development of psychosis is very linked to childhood trauma, and so a real re-understanding of all the diagnoses and where these problems may come from. But the studies that were done by Hind Khalife also showed, and this was very important to mental health professionals as I am, that people are most likely to tell us first, and why us asking routine inquiry is so important. If we don't ask, people don't tell us, and yet we're the people who are seeing people. If they've got care coordinators, they're in hospital, and things like the very strong correlation between childhood abuse and suicide. So kind of a context really of why mental health services, all services, should be trauma informed is without a doubt all the evidence is now, as if we needed it, but we seem to have needed this evidence to say that trauma and mental health are absolutely linked. The next slide, please. I'm going to minimize myself so I can see my slides. So for me, running a women's crisis house, and I'll tell you a little bit about that. I've been doing that for 25 years and really seeing the changes. The women were contacting us saying they were afraid to come out of the house to come and get help. So women who might have used drop-ins or been seeing their care coordinators, all of a sudden lots and lots of interventions were via technology. Many women didn't have technology and felt very kind of afraid of technology, of being recorded. So kind of tapping into feelings of somebody watching you, leading to what is called paranoia, but actually again comes from very real places of having been watched and controlled. A sense of being contaminated, that somehow the virus was something they were spreading, that one, they might catch it, but two, some sense that there was something kind of dirty and that they are contaminating others for coming to services where they have to all of a sudden put a mask on, put gloves, you know, alcohol gel, all those kind of things suggesting there is something wrong with them. Absolutely, as other people have talked about, the increase in domestic and sexual abuse, which we saw in our services for the people who we serve, but also for the staff. And we kind of rewrote sexual domestic safety protocols, very simple ones for crisis teams for A&E. So really the safety planning protocols and interventions that domestic abuse services were used we were kind of doing shorthand ones of those to try and help all the kind of gateway areas to services. Obviously a real increase in isolation, and that isolation leading to anxiety, feeling very unsafe, leading to acute crisis, but people then not being able to come out to get the help to manage that acute crisis. Without a doubt, I was hearing from Black women, and I saw Black women having a much greater fear of where the virus came from, understandable fears relating to kind of history around somebody is trying to do something to us. I saw it in the Black women in my own team who were much more afraid of getting the vaccine, again, for all sorts of justifiable reasons, but also suffering most with COVID, with symptoms and trauma and loss in their own communities and families. And I really saw that in my own team and that the women we serve. And lots of the group work was suspended and not seen as essential, the face-to-face work not seen as essential, when actually for lots of women, some of the work with health professionals is their only contact. So these were kind of some of the things that we are absolutely seeing and still seeing, and tried to find creative ways of connecting with women. For example, with work, I'll go to the next slide. The service I run is in a big house in Islington. So we were encouraging people, women, on their daily walk out to kind of walk by the house, not to come in, but we could come onto the doorstep and just have a chat. So giving a focus for coming out, and that focus then meaning somebody sees you, somebody hears you, somebody smiles, and knows that you're struggling, sees you really and holds you in mind. So the actual service that I provide is the Drayton Park Women's Crisis House. It's an alternative to hospital for women in acute crisis who would otherwise be admitted. It's a women-only team. It developed with lots of women with lived experience using services, really came from the women's movement in mental health. And the service can accommodate 12 women to come and stay at any one time, and sometimes with children, and can offer a short stay with a range of interventions, kind of contain the crisis, validate experiences now and in the past, and offer some new ideas and support for the future. So the next slide, please, which is probably a very busy one. So I suppose this was just an opportunity to kind of show the model of Drayton Park as a trauma-informed model to working with women. And this model is really what we're expanding at a macro level in our trust to become a trauma-informed organisation, which I'm sure many of you have heard. Just going to close the door because the cat has opened it and the doors are very noisy. So I'm sure many of you are aware that nationally there's a move to trauma-informed approaches. In our service, we've been doing this for 25 years. So again, these trauma-informed approaches have really come from the women's movement and the Black women's movement and the LGBT women movement in kind of pushing for a different way of providing services. And we very luckily had this 25 years ago at Drayton Park. So those ideas of collaboration and collective voice, so services developed with women who've used services, what's important to them. The language we use, as we've heard today, how we describe people's behaviour, how we describe what's happened to them, really creates the relationship and makes meaning. Absolutely, from the beginning, having a women-only service with a women-only team was really recognising that women need a safe space, a women-only safe space to feel safe, to gather strength and to disclose and share what's happened to them. As an acute crisis service, we use much more kind of psychological containment rather than kind of observation and risk management. And again, really kind of trying to help the whole trust, as Alexis was talking about in some of the other services. It's not pretending that everything, open doors, nobody will ever be restrained again in mental health, but kind of acknowledging the trauma and how we work with somebody can really ameliorate the re-traumatization, and more transparency about why we do the things we do. Iatrogenic trauma, so as you were talking about, that a trauma-informed approach is really to not do any harm and to recognise the harm of the benefit system, people having to kind of prostrate themselves, tell their story every year for their PIP application, how traumatising that is, And again, during the pandemic, issues of benefits and getting out to get money and things like that, that people would have preferred to kind of starve than have to go out to those appointments or fill in all those forms on their own. Very importantly, we've always had body work at Drayton Park for 25 years. We've had true trauma body therapists instead of kind of an OT or more kind of activity based with our budget. So we have body sessions for the women provided by a woman who really understands how the body holds the trauma and how much unspoken work can be done with those kinds of interventions. So I won't go through this a lot, but another time, you know, there's lots to say. But if we go on to the next slide, it was just really to put one of the posters up in the house, because it is kind of about, you know, how do you demonstrate who you are to kind of a diverse group of women. So this is just one example in the house. There's a notice board that is just really speaking to LGBT women who come and stay in the house. If we haven't kind of promoted this in our language, so a trauma-informed approach, and really is also about our environment. So again, in our trust, we're very much we're building a new hospital. How can that be trauma-informed? From reception onwards, what kind of images do you have that speak to a diverse group of people who come in, as another way of communicating that whoever you are, you will be kind of respected and celebrated. The next slide, please. Just another painting. So just kind of talking about kind of creativity, diversity, how you can show that in all sorts of different ways. So it's a painting that was done by a woman who did a residency from Disability Arts Forum. And, you know, it's just really, really important that in mental health and with trauma-informed approaches, it isn't just us as individuals providing trauma-informed therapeutic relationships. It is how the whole environment holds our principles and values, and how it welcomes diversity, and that those things are as important as the kind of direct relationship. Next slide, please. So kind of what can we do really? It was just a kind of summary. I've pulled this from different trainings that I've done, but it's so importantly what we call routine inquiry, that is absolutely at the heart and mandatory for anybody coming to services, that we ask people regularly, do you feel safe with the people in your life? Since we last saw you, has anything happened to make you feel frightened? At first assessments, has there been anyone who has ever hurt you or frightened you, and how can we support and help you? That we reflect on our communication verbally and non-verbally. Do we collaborate where possible, and we offer choices? You know, even if it's tea, coffee, drinks 24 hours a day, it's still a choice. Is there a choice for a woman to lead on your care? What are the choices about visitors? What you can wear, what time you can get up? It's so important to be very transparent about what choices are there in the service that you run. Do you recognise the trauma that people have suffered and how it impacts on how they behave? So justifiable anger that gets mislabeled as kind of aggression. And if we understand trauma and fear and how we respond and behave in a respectful, dignified way, it reduces the kind of aggressive outbursts where people are protecting themselves. How can you change your environment to make it more trauma-informed? What kind of posters do you have around? Even when we put posters up about we don't accept violence and abuse against our staff, it really should have to be posters about, you know, we aim to have a safe environment for everyone, and you don't have to accept that kind of behaviour either, that for nobody this should be their experience. And what do people need from their managers and organisations? That trauma-informed approaches, working with women in this way, and men, because we need to change how men behave. It needs to be held by the organisation. So how does the finance department, how does HR behave? How do we build our environments? And how do we support and supervise staff? So again, I know that most in mental health trusts now, we have staff wellbeing teams, and this is new. So how are we really looking after the people who are on the front line so that they don't cut off from the people who are coming to us for kind of a trauma-informed response? And the next slide, I think that's it really. So I kind of went through quite quickly, but just very much wanting to kind of highlight that I really think COVID has given an opportunity to bring some of these issues to a wider audience. I'm certainly kind of being pulled in all sorts of directions from people who never wanted kind of trauma training before, domestic abuse training. Our trust is just finalising creating all men's wards and women's wards, which we've been kind of campaigning for 30 years. So there are some really positive changes that I hope we can all kind of harness together. And thank you very much.
Thank you, Shirley. And once again, I think I wish we had all afternoon, but thank you for your presentation. So our next speaker is Janae Walker, who is All Black Sisters. So over to you, Janae.
Hello, everyone. Thank you so much for having me. As has been introduced, my name is Janae Walker. I'm the Legal Policy and Campaigns Officer at All Black Sisters. Apologies in advance because I don't have wonderful slides for everyone, so I'll try and retain your attention with my words. To introduce the organisation All Black Sisters, or SBS, was established in 1979. It's based in West London, and we're an organisation that assists and supports Black and minoritized women and children, primarily, or the overwhelming majority of them are also survivors of gender-based violence. Many women and children arrive at SBS having experienced gender-based violence, also interrelated problems of homelessness, poor mental health, poverty, and of course issues related to their insecure immigration status. We manage around 500 cases a year, and we also operate a national helpline where we receive about 6,500 calls a year as well. In recent years, which I'll go into a bit further within this discussion, we operate a no recourse fund to enable migrant women who are subject to the no recourse to public funds condition temporary access to accommodation and subsistence, given that they're often excluded from mainstream services. So essentially what SBS does is, through advocacy, we assist women and children to obtain sort of immediate protection, but also to support them holistically so that they their long-term security is guaranteed, and that we can improve their emotional well-being and assist them in recovering from what they've experienced. This can involve helping them with access to sort of housing, mental health services, but also to welfare, legal advice, representation in family, civil and criminal proceedings, for example. At the centre itself as well, pre-COVID-19, a lot of our work is also about trying to provide a peer support network for women, given that so many of our service users have insecure immigration status. Some of them don't speak English, some of them are here without any sort of support networks in the UK. We deliver sessions, English classes, but also support groups to try and provide women with an alternative community that can welcome them and set them up for the future. And then finally, of course, SBS also carries out policy campaigning and legal work, which is where my role comes in as the legal policy and campaign officer. All Black Sisters work, a lot of it is really trying to draw attention to the fact that Black and minoritized women are really vulnerable to high rates of gender-based violence, including domestic homicide and suicide, and to think about what are the reasons behind that. There's, of course, a number of barriers that Black and minoritized and migrant women face in terms of accessing support and safety. And the one that I'm going to focus on today is in relation to insecure immigration status and the no recourse to public funds condition. As has been expressed by many of the speakers so well today, of course, the experience of gender-based violence in itself is traumatizing and causes so many problems for women in terms of their mental health and how to respond to what's happened to them. I think what we try to draw into the picture as well is to think about how that experience of gender-based violence intersects with the experience of immigration laws and policies which subject women to a really hostile response from services when they seek help. Thinking about the ways in which the ongoing uncertainty about their future in the UK really creates this long-term precarity where there is no guarantee about what will happen to them, whether they will remain safe, whether they will be returned to their countries of origin, how long they're going to be waiting in the asylum system, for example, before they can really get on with the work of recovering from the gender-based violence that they've experienced. I think when we're thinking about the COVID-19 pandemic and what that meant for the experience of women subject to gender-based violence, it's really important to also highlight the crisis before the crisis, as it were. As I said, in terms of the barriers that migrant women face, you may know that Southall Black Sisters has been campaigning for the last few years, particularly in relation to the Domestic Abuse Bill, which is now the Domestic Abuse Act, about the fact that there is essentially a two-tier system of support in the UK, whereby your immigration status excludes you from mainstream support in many cases, because unfortunately, in many ways, rather than being treated as victims or survivors, first and foremost, many women receive care through the lens of immigration and the fact that they could be perceived as potential immigration offenders. Southall Black Sisters struggles on a daily basis to secure women's access to alternative accommodation, for example, to enter into refuges, as was highlighted in Lucy's presentation. And it's probably just, I'm sure many of you listening will know, but no recourse to public funds is a condition applied to migrants in the UK without indefinite leave to remain, which prevents them from accessing most forms of state funded benefits. But importantly, that includes universal credit and social housing. It can apply to a diverse range of people, including sponsored skilled workers, family members of British citizens, but also asylum seekers and undocumented migrants as well. As a result of the no recourse to public funds condition, what that means in practice for those experiencing gender-based violence is that many refugees are unwilling or unable to accommodate migrant women at their point of crisis, not only because of the shortage of free spaces, as explained previously, but also because there is no universal credit to essentially cover the cost of their stay at the time that it's needed. Some figures have already been highlighted. The one I have here is also from Women's Aid, which shows that for 2017, in a single year, 4 in 5 Black minoritized women were turned away from refuges. And it's for this reason that we've had to long resort to housing women and alternative sort of B&B accommodation and unsatisfactory, albeit really essential services for women, given their exclusion from refuges and other community services. The other thing to draw into this when thinking about the experience of gender-based violence for migrant women and how that impacts upon their mental health is to consider the deliberate and steady expansion of immigration controls across society under the banner of the government's hostile or compliant environment. What that looks like in practice will be things such as data sharing agreements between the police and the Home Office, so that if a woman reports domestic abuse to a police officer, she may be served with enforcement paper, sort of immigration enforcement papers as a consequence of seeking help. Of course, immigration officials stationed in local authorities, landlords inquiring about the immigration status of their tenants, and charging policies for migrants in NHS care. In our experience, what these mean in practice is that they actively deter migrant women subject to gender-based violence from seeking help, because they are really fearful about what the consequences might be, that they will be pursued, that they will be separated from their children, that they will be detained, that they will be deported back to their country of origin where they are unsafe. And what we know as well is that perpetrators are well aware of this, and that perpetrators will deliberately weaponize women's insecure immigration status as a form of coercive control. Women will be told, if you tell anyone, you will be deported from this country. You will be, I am a British citizen, I brought you here, I have the power to get you out of here. And that really adds another layer when we're thinking about the level of fear and the level of, this experience of entrapment that so many survivors face. Unfortunately, in our experience, many migrant women's interaction with social services, we can see how that hostile environment has filtered through in terms of the cultural practice, in that a lot of our engagement will be, of course, with children's services. When women and children seek support under Section 17 of the Children Act, we have real difficulties in obtaining any help whatsoever for single women who are subject to no recourse to public funds. but the responses can really obviously differ across areas. It can include, you know, an outright refusal to assist women and children because the woman is subject to no recourse to public funds, unlawfully providing women with immigration advice, attempting to mediate with abusers to return women and all their children to the partner because he has British citizenship, or insisting perhaps that the safest option might be that you go home. As you can imagine, these responses are incredibly harmful for women's mental health when they're dealing with the trauma of gender-based violence. And when it comes to the COVID-19 pandemic, I think what we saw here is an intensifier rather than anything particularly new. I think that the inaction on the part of government, in our view, in terms of anticipating a rise in violence against women and trying to mitigate that, combined with a real refusal to suspend these sort of punitive immigration policies, meant that so many women were trapped, essentially. You know, we've heard very often about the experiences of women being locked inside the home or living with abusers during lockdown, and that sense that there is nowhere for them to go. I think that's really just intensified by the continuation of immigration controls, because it adds another layer of, even if I seek help, who will help me? Will I be the one that is pursued because of my immigration status? To quote one of the women who we support, she said, "I was afraid to take any steps because my immigration status was not secure. My in-laws had my passport. They told me if I left the house, alarms would go off and I would be arrested and deported, and I believed this was true. I thought it better to tolerate the abuse because I could not go back to my country and ruin my father's honour. My situation was getting worse and I was abused on a daily basis." So hopefully this gives a sense of the immense stress that women are under, which is really exacerbated by this looming fear that they are going to be the one pursued by immigration authorities. And you know that there was real action taken on the part of many organisations to try and ease some of those restrictions. So, you know, we saw a growing consensus building about the cruelty of no recourse to public funds and what it means for the well-being of women subject to gender-based violence. You know, organisations such as the Local Government Association, the Work and Pensions Committee, and charities in the children's sector were all calling for no recourse to public funds to be lifted, but that never occurred. What we know now, unfortunately, is that particularly in the first few weeks of lockdown, that there was a surge in domestic homicides, and figures suggest that Black and minoritized women were overrepresented in that cohort. I think it's important, thinking about the theme of today's discussion as well, is just, of course, the homicide figures are just one part of a much wider picture of the circumstances faced by Black and minoritized and migrant women during the crisis, the consequence of which are much more difficult to quantify. I think the experience for many migrant women of being able to get to a point that they feel able to seek help to then be turned away by numerous authorities because of their status is incredibly re-traumatizing, and in often case means that they return to their abuser. We have the example of a young woman called Farah, who was in the UK as the dependent of her father, who was verbally and physically abusive towards her. She said when she tried to escape, she made many calls to the council, to the National Domestic Violence Helpline, and they all said the same thing: I have no recourse to public funds, they can't help me. And some of them said it's not the law to help me. She was compelled to return to the home with her father, and she spent most of the day trying to sit at bus stops to wait for her father to fall asleep. Fortunately, she was able to reach SBS, and we've been able to provide her with alternative accommodation. Of course, in terms of Southall Black Citizen Services, we've done all that we can to transform the delivery of support, particularly to support migrant women's mental health, thinking about the fact that many of them are so isolated, trying to transfer our services such as counselling to telephone counselling, trying to think about ways to deliver our support group remotely. But of course, because of the wider conditions within which they live, we know that there are many more women who we've been unable to reach. And what's needed now and what's next? I guess our call for adult social services would be really just to ensure that all vulnerable women and children, including survivors of abuse, are treated as victims and survivors first and foremost, irrespective of their immigration status. You know, it's our view that immigration enforcement does not have a place in social care intervention, and that the main priority should be always to safeguard vulnerable women and children without discrimination. We've recently contributed to guidance, I think specifically for children and family social workers, published by the BASW, which is, you know, to provide domestic abuse practice guidance. But what I've really tried to outline here very briefly is the ways in which the experience of gender-based violence at the intersection, the experience of gender-based violence intersects with punitive policies, immigration policies, and that not only impacts on women's ability to seek help, but it, you know, when they're viewed as potential immigration offenders, that really erodes their trust in services and can heighten the coercive control that they experience. It means that women's mental health is really damaged in a sense because they're dealing with the trauma of gender-based violence, as are other women or any other survivor, but it's really combined with this heightened sense of fear due to their precarious status and the immense worry about their future in the UK and what might happen if they are unjustly returned to their country of origin. Thank you.
Thank you, Janae, and I'm very impressed that you did that without any slides at all, so thank you very much. We do have a little bit of time. Our speakers are available as a panel to answer questions. No? Okay, well, I'll draw the webinar to a close then. I just want to thank all of our speakers again for some really excellent presentations and food for thought, and to thank all the delegates for joining. As I said earlier, the slides will be made available by the 18th of May and the recorded webinar will also be made available. And thanks on behalf of ADASS to our business partners, including the home group, for their support so that we were able to put on some events in Mental Health Week. So thank you everybody, and we hope to see you all again soon. Bye.